Uh, Thank you for joining us. We are calling these sessions COVID-19 Dialogue. And the purpose is to have a conversation with global experts around the key issues on managing this huge pandemic and, and what are the lessons learned from the history of pandemics or epidemics in the past, and what can we do to better prepare us for this. So today, I'm honored and very happy to present to you Dr. Tom Kirsch. Professor Kirsch will introduce himself, and then we can get into a discussion. So Tom, why don't you go ahead and tell us about yourself?
Good morning, everybody. It's an honor to be here. I'm an emergency physician and an epidemiologist. I have a master's in epidemiology as well as my MD. My background is I spent most of my career doing disaster work around pretty much around the globe and domestically within the US. Disasters in South Asia that I've been to include the Nepal earthquake in 2010 and the Pakistan floods in the Nepal earthquake in 2015 and the Pakistan floods in 2010. I worked for a while for the WHO doing field epidemiology related to immunization preventable diseases, and I worked in Liberia during Ebola. So I have quite a bit of experience working in different settings around the world, as well as working in infectious disease outbreaks. And so the current COVID-19 pandemic has been an important part of my recent work. So.
Thanks, Tom, and thank you for your time. What I'd like to talk about today is in relation to what you wrote in the Atlantic and Washington Post recently, and which is on top of everybody's minds, especially those who are working on the front lines. And that is, how do we keep the healthcare workers, the hospital care workers, especially those working in the emergency departments and ICUs and the operating rooms, how do we keep them safe? And I know you worked in an Ebola crisis where I guess the infection transmission rate was much higher, the risks were higher, I guess, though the data here is increasing. So I'd like to, what I'd like to do is to hear your thoughts first, summarizing how you see the lessons learned from other epidemics applied to this one. And then what I would like to do is open the discussion to the audience. And before you start, what I would like to do is just share with folks here the email address that you guys feel free to write to us on, and that should be on your screen now. And that is, the email is coe.te@aku.edu. So please feel free to write to us your emails. And again, Tom, coming to you, lessons learned from prior epidemics and pandemics, and what can we do to improve the safety of healthcare workers?
Great. So there's a big difference between Ebola and coronavirus. The biggest difference, of course, is that Ebola was spread purely by contact. The second biggest difference is the mortality of Ebola is somewhere between, if you get it, 40 to 50%, as high as 60% in some of the more austere settings. Coronavirus is respiratory spread, droplet spread for the most part. It is also has a relatively low fatality rate. We don't know the number. The various numbers, when it first came out, people were saying the mortality rate was around 3 to 4%, which is quite high. In Italy, the early experience was the mortality rate was over 9%. The best guess by a lot of experts is around 1%. And what that points out is even now, 3 months into this outbreak, we still don't have sufficient epidemiologic data on this virus to understand its case fatality rate, to understand its transmission specifics, to understand risk factors for different levels of contact, to understand safety of different types of PPE. And that's one of the biggest things that's affecting the response around the world now is we despite 3 months, haven't done sufficient testing or quality studies to answer all of these critical questions to protect healthcare workers and to protect the public. And so I find that very disheartening, and keep waiting every day for the first big population-based study to come out so we can better understand this virus, and that still hasn't happened yet. In Ebola, the reason a lot of people died initially is they didn't understand that this disease even existed or that it's what was propagating it. It took months to make the first diagnosis because there were no testing facilities in Africa that could test for the virus. And it occurred in a place that was 1,000 kilometers away from the prior outbreak that had never been in that area. This virus, the coronavirus, is different because China identified it to the world relatively quickly, within a few weeks of their initial understanding that it was being transmitted in Wuhan. But again, we haven't been able to implement appropriate levels of protection in our society other than for large shutdowns. For healthcare workers, I think you've read my pieces, and having worked in Liberia, I was acutely aware once I heard of this virus of the potential risk to healthcare workers, and it became a rallying cry for me, and I was making a lot of waves and made a lot of people angry, insisting that we start protecting our healthcare workers right away, because I'd been down that path. And in Ebola in West Africa, healthcare workers started dying at a rate up to 30 times higher than the regular population. And as a result, everyone quit going to work, and the entire healthcare system in the 3 countries, Sierra Leone, Guinea, and Liberia, entirely shut down, and there was no healthcare available. And so healthcare worker protection is a huge part of any response to an infectious disease. And our government and many governments around the world have not demonstrated the capacity to do that appropriately. Here in the US, as the event is ramping up rapidly in different cities around the country, we're already recycling our face masks. We're reusing them, trying to sterilize them with UV light. We don't have necessarily the appropriate levels of covering of our bodies. We don't have like full suits. We're not necessarily doing hair cover. And there's a lot of concern about that. The concern is very justified. In Italy alone, the numbers are that approximately 5,000 healthcare workers have become infected with coronavirus, and about 50 have died. The good news is that's less than 1 in 100. The bad news is there's 50 dead people. In Spain, the numbers are even worse. The latest estimate I read last night was about 9,500 healthcare workers have become infected. And when I refer to healthcare workers, I'm not just talking about doctors. I'm talking about doctors, nurses, the technicians, the respiratory therapy people, the people who register patients, the cleaning staff, whoever is working in an infectious environment. So in Spain, the number is almost 10,000 people. The current reported deaths was around 22, but those numbers, I believe, are lagging. So the concerns are very real. And the biggest thing that we can do as providers, as healthcare workers, is we have to recognize the risk. One of the problems around the world now has been the complete denial of the severity of this infection. Even as late as yesterday, one of my friends said, "Oh, it's just the flu, why do we care?" Well, that's a widespread, unfortunate belief. Well, it is just the flu, maybe, because it's a respiratory spread virus. But even in the best guess, it's going to kill 20 times. It's going to have a case fatality rate 20 times higher than the flu. The flu around the world every year kills, in the US, it kills between 30 and 60,000 people just in the US. And around the world, it kills over 1 million people every year. So if you multiply that by 20, that's going to be 20 million deaths around the world.
Yeah.
And so this is a serious, extremely dangerous virus that we can't take for granted at all, because we don't want to be one of those dead healthcare workers. And frankly, I don't want to be in an ICU on a vent and not be able to work for 3 weeks and be out of the mix. So the first thing that is imperative for all of us is to recognize the severity of this. Even my colleagues were downplaying the importance of this virus as recently as 2 weeks ago. But it's up to us to begin to initiate. This virus is circulating everywhere, by the way. You may not have, they might say, oh, there's no cases in our area. There's nothing. It's not true. There's cases everywhere. It's just that we don't have the test to prove that that's going on right now. In the US, that remains true. And so once there is a death from COVID in an area, that implies that there's at least 100 other cases out there circulating or more, just because of the epidemiology, the case fatality and epidemiology. So the first thing we have to do is work together as a group to make sure that our hospitals and our systems are preparing for this and responding to this. We need to take care of ourselves immediately, which means in America, in most of the cities where the cases are beginning to ramp up, we're doing mandatory use of face masks the entire time you're on your shift and you're working. Some people are doing mandatory glove use. Some people are doing gowns their whole shift, whatever they have available for protection. But it's really up to us as healthcare leaders to make sure that whatever protection is available is done immediately. And one last comment, in Ebola, when I was working in Liberia, the biggest thing that prevented people from protecting themselves is they didn't believe. And we would go around to the different villages scattered around the country, and they'd say, oh, it's a lie, it's a plot by the government, it's some Western thing, it's just another virus, we don't care, it's no big deal. And we found that the only time behavior changed is when someone in that town or that village or that family died. And then the people recognized the severity of the illness and changed their behavior and protected themselves. And literally within a month or two, we turned the tide of that epidemic. And it wasn't because of anything we did as doctors or public health people. It's because people finally got afraid and finally recognized the severity of the illness. And my argument to you all is be afraid, start now, and make the changes necessary to protect yourself and to protect your patients. So that's my statement.
Thanks, Tom. I have one question, then I'll come to the whole discussion around how afraid one should be, and how do we message it so that healthcare workers are careful, extremely careful, but are still able to provide care. So before I ask you to answer that question, I have a question from Dr. Farid. He's asking, and I'm sure you've heard this before, is do you recommend any prophylaxis for healthcare workers who are exposed to high-risk areas like in emergency department or ICU?
There's a lot of talk about prophylaxis. And I actually did a search 2 days ago, because the big talk is that chloroquine's the magic drug and going to save everybody. And I can say definitively that that's a bunch of crap. The chloroquine data that's out there and the hydrochloroquine is based on a couple of small Chinese studies that showed marginal improvements in hospitalized patients with severe illness, and a reduction in death of 10 or 20%. It's not a magic bullet. It's not going to prevent or cure everything. So that's one. Two, the data are literally based on just a couple tiny sub-studies that were poorly randomized and not conducted to the quality that we like. But based on the fact that there was some benefit, one of the Chinese societies 6 weeks ago made an expert panel that recommended that chloroquine be used to treat anyone with a diagnosed case of a COVID-19 infection, not for prophylaxis. There's really been no other data or studies that have come out of that to prove that the drug actually works. they're being conducted now in Europe and the US. There's a number of studies. And in New York City, where this disaster has entirely overwhelmed hospitals now, they are using chloroquine widely for people who are critically ill, not for regular people, but they're using it just because they don't have any other choices. So there's been no studies that I was able to identify that show that taking chloroquine will actually prevent transmission or protect in any way. So my concern would be that people would be taking it, think that they're falsely protected, and in fact they wouldn't be, and they would miss out on doing the appropriate barrier protection and mass protection. So I personally would not take it. I think if I was sick, critically sick, giving it to a patient, I would do that if I had it available, just because there is nothing else that we can do. The antiviral studies so far have been shown minimal benefit. The Kaletra drugs, the AIDS antivirals clearly don't work, or pretty clearly don't work. There's a couple other, remdesivir and another, that have some potential utility. But again, even the preliminary data on any of these medicines don't say it's a cure. It just says it may reduce mortality a little bit. So just, you got to keep it in mind that maybe this helps, but it's not a cure for this infection, whatever we have out there.
Mm-hmm. That's very helpful. Tom, can you address this issue of self-protection, and how effective is the infection control measures such as hand washing, personal protective equipment, and then we'll come to the question around what to do when you don't have those things available and how do you reduce your risk. I also like to address, as you address this question, the concern and the fear amongst healthcare workers, and why, I guess, by talking about the effectiveness of some of these interventions that you can do on your own, you can perhaps reduce your risk significantly. Right.
So the good thing about this virus is this is not the apocalypse. There was a study that came out yesterday that estimates the case fatality rate is 0.66%. So it's 1 in 1,500 people. 1 in 150 people. So, and again, if you look at the skew across populations, over the age of 60, and particularly over the age of 70, the mortality rate goes up markedly. It goes from under 1% to as high as 10+% in people older than 80 years old. And so there's been relatively rare, in fact, extremely rare deaths in younger age groups. The first child died in the US 3 days ago, an infant less than 12 months old. There was a teenager that died in Europe a couple days ago. But those are very rare. So the death rates in young, healthy people are infinitesimally small, equal to or less than that of influenza. And so generally for healthcare workers, the risk is quite small if you get the illness of so even getting hospitalized, let alone dying from the illness. And so, we have to keep that in mind. And I think you're all aware there's well-described risk factors with health history of coronary artery disease or heart disease in general, respiratory illnesses, asthma, COPD, diabetes is a big one, and even hypertension is a risk factor for increased mortality in this event. And so by proper screening and by placing older healthcare workers in a non-infectious environment and stuff, the actual risk to us is small. And so far in the US, there's been, everyone goes to work, we go in and do our thing. There was a small strike by a few Spanish healthcare workers a week ago because they felt they didn't have proper PPE. But if we're careful, if we do the right thing, the risk is small. So doing the right thing, the majority of this infection is going to be transmitted by, because droplets accumulate on horizontal surfaces. We touch the surface and like our keyboard, and then we rub our eye or pick our nose or lick our finger to turn the page of a book. And so it's a matter of hand hygiene is of paramount importance. It's estimated that over 50% of transmission occurs through touch and not through breathing. So the combination of good hand hygiene, and we'll talk about that, and wearing a barrier protection is critical and will reduce the risk of infection markedly. There's very specific recommendations out there by the CDC, by different organizations, the Europeans, the Italians, the Chinese, although I don't read Chinese, that talk about different levels of protection and different barriers. But at the least, it's hand hygiene and a mask continuously. Hand hygiene, my rule of thumb that I learned in Liberia during Ebola is anytime you change a venue, anytime you move to a different geographic space, you have to wash your hands. In Liberia, literally in front of every building, and even within buildings, particularly healthcare buildings, but also even the Ministry of Health, they had buckets of bleach water. They had coolers with spigots, and you would wash your hands every time you move through a door. And that's what I do here at home. My wife and I have a little stand with hand sanitizer at our front door. We hand sanitize whenever we go in and out of our house. When I go in my car to the store to buy stuff, I have a bottle of hand sanitizer in my car. And when I step back into my car, before I touch anything, I hand sanitize because I've just been in a grocery store or a gas station or whatever. And so anytime you change venue, you need to clean your hands, period. You just have to get used to that. It became second nature in Liberia because we did it literally 50 times a day, no matter where we were. And clearly in clinical areas, obviously, if you're seeing a patient, when you're done seeing a patient, you have to hand sanitize immediately. Regarding masks, there's been a bunch of studies on masks. An N95 mask, if you have it, is good, is great. Regular surgical mask, however, particularly if it's worn by the patient and by the provider, is estimated to have the same level of protection as an N95. And the key there is any patient who's suspected of having COVID, particularly any patient who's actively coughing or sneezing, needs to have a barrier in front of their face, period. Absolutely no question about it. And whether that's a mask or a scarf or whatever, you need to reduce the droplet transmission in that patient. And I highly recommend that in every setting that you work clinically, you adopt that standard now. If you have sufficient masks, then the patient should have a mask. If not, then you can makeshift pieces of cloth or whatever necessary. But that's a critical way to reduce the transmission of this virus. So the combination of masked patient, masked provider is good. For the higher level procedures that generate droplets, such as intubations or giving nebulized therapy or using a CPAP or a BiPAP or some type of respiratory support or bagging a patient, ideally you would be in a PAPR or a protected, an air-powered respiratory device with a hood to protect yourself would be the ideal level of protection. But again, for the most part at work, we are simply wearing masks. People are moving to wearing head covers. I don't need to do that much because I don't have much hair, but head covers. And gloving if necessary in between patients, but certainly hand sanitizing frequently.
Great, thanks. Tom, we have about 10 questions already, so I'm going to run. Some of them are more broad public health kind of questions. The next question is from Carrie Shannon. She's one of our residents in emergency medicine at Hopkins. And she's asking, can you speak to what type of strategies are being used in slum communities and other crowded areas where people are going to have a real challenge social distancing?
Well, unfortunately, I can't because I haven't heard any strategies. The big issue here is, so we know now, we've proven it definitively in China, in Korea, and now in US, in Washington State and California, that social distancing through fiat, which means the government says you will stay home, works. The epidemic curve has markedly altered within 2 weeks of those imposed restrictions. In lower and middle income countries where there's large swaths of very crowded people, you can't do that. They tried that in India. They said, we're going to shut the whole country down. And immediately, of course, those marginalized people with no economic resources started starving. And so I personally have not seen a good plan out there. There's people working on it. There's a lot of chatter from the UN in that area. There's been stuff done, but I don't have any magic answers for that. And that's where the real concern is, because we don't have a good idea of how to stop transmission in those environments.
Yeah, and I think you, Kerry, is really pointing to the knowledge gap in this whole area. There are so many different settings where there are going to be such different challenges. I'm going to move on to the next question from Elizabeth Surly Mitsos. I'm sorry if I'm not saying your name right. She's saying, nice to hear your voice again, Tom. And her question is, what was it about Ebola that called for such comprehensive PPE in the context of Ebola as compared to COVID-19? Is there something different about the infectious nature of Ebola, or is it that the severity of an Ebola infection that made the PPE more important?
So the answer is yes to both of those. So Ebola couldn't transmit, Ebola probably did not transmit through intact skin, but the average human body, you look around, I have little scratches on my hands, and I have a little ulcer right there. And if you look, we have little abrasions and openings and bruises and stuff all over the place. And Ebola is highly infectious if it reaches a mucous membrane or a non-intact skin piece. And then it killed 50%. And so the level of protection had to be extremely high, because we learned that even the slightest slip, you didn't have the cuff of your glove quite tightened enough, then you could die. And so the drawback here is, ideally around the world with this setting, the healthcare workers would be, if you looked at China, the photos coming out of China about a month into the outbreak, healthcare workers were wearing full Tyvek bodysuits with foot coverings and goggles and head protection. So they were encased almost to Ebola-like levels to prevent infection. They didn't wear the double layering like we did in the Ebola response. But even in the US, we don't have that. And reading my editorials, you see, I'm bitter about that. To me, it's appalling that even in the US, we're rich and we spend bazillions of dollars on healthcare. The expectation now with healthcare workers is we slap on a surgical mask and put on a crappy paper gown and go into a room. And ideally, that would not be the way. We would wear a much higher level of protection. We would have full Tyvek suits, goggles, masks, complete hair covering, etc. And that, to me, is a huge failing of governments around the world, not just in the US, that we aren't able to protect healthcare workers appropriately.
I have a question from Shalini Singaravelu. She is asking about the community health workers. And these are people who, as you know, go home to home, and they have such a critical role in maintaining public health. And she's asking, what are some of the recommendations for community health worker programs and activities? So
my recommendations, and as my best guess as a relative expert on this, the virus is most likely to be transmitted in a closed space. It's like measles or TB or any of that stuff. So ideally, you don't go into people's houses. You do your community health visit wearing a mask or a scarf or some type of facial protection, and you meet outside, because being outside is the best place to be. I go for a walk every day now because UV light kills the virus. The circulating fresh air blows whatever droplets are in the air away immediately within seconds. And so the safest place that you can be in any of these events is outdoors and 6 feet away from people. So ideally, you would hold your community health visit outside in a sunny spot. and would remain as far away during the questioning and answering period, if you're doing patient education, et cetera, as 6 feet or 2 meters, sorry. So that would be my thoughts.
I have a question from Maliha. She's from AKU, and she's asking about what else can the healthcare workers do besides PPE? And I think you may have addressed those issues. So once again, if you can just talk about, well, PPEs are very, very important. What else can they do?
Well, I think the outdoor thing is really important, and a lot of the hospitals in the U.S. now have moved to having screening of patients outside hospitals in tents, which have better air circulation. And so, having worked in low middle income countries, there's no reason to not have your clinic outside if it's not monsoon season, and if you have a shady tree you can sit under. And so I think moving to an outdoor environment is a really good start. I think that keeping the 2 meter rule in force is a really good start, because even I, as a physician, I can do 90% of my diagnosis simply by asking the appropriate questions. And so conducting an interview at a distance of 2 meters, sitting across the table or whatever it is, I think is a good way to do it. And to only get into proximity if you in fact have on a mask, if you in fact have hand sanitizer available, and if ideally the patient has a mask also. So distancing, fresh air, and barrier protection are the answer for all of these things. Great.
I have a question from my colleague Talha from AKU, and he's asking, I guess, $1 trillion question. And the question is, how long do you think it would take to control the pandemic? And once controlled, how do you suggest bringing life to normal everyday duties?
Well, the latter part of that question I won't answer, because that's for the economists out there, and I'm just a doctor. So the thing about this infection is it's a virus. Viruses transmit the way viruses transmit. We knew when I first heard the China virus, I knew it was going to transmit. I knew how it was going to transmit, because it's like a math problem. It is a math problem. We model these things. The variables are that it transmits across geographic distances at different rates, and it transmits within populations at distance rates depending on crowding and stuff. So the model that I can use best is the American models that are out there, and some of the European models. Currently in the US, we have a very large country, right, with 320 million people spread out over hundreds of thousands of kilometers. It's the second largest country in the world geographically, I believe. So we have hotspots scattered around, particularly on the coasts, which are big transportation hubs that are coming from China and Europe. And so most of our early infections have been on the 2 coasts, in Washington State and California, and now in New York City, Boston, Miami, and soon to come to DC. The infections are moving inland and inward as with transportation hubs, et cetera. So the predictions, for example, in New York, which has the worst outbreak right now, where the hospitals are entirely overrun, and they have field hospitals set up in Central Park, is that it's going to peak somewhere between 7 and 10 days in New York City, and then tail off over the course of the next 2 to 4 weeks. It's not going to go away. It's just the transmission is going to get lower. The peak in DC is expected to begin. It's beginning now. We're seeing more cases. Are you seeing more cases, Junaid?
Yeah, I think we feel that next week, 10 days is going to be worse for us. We're beginning to
that's my expectation here. It's going to be worse for us, but it's not going to be the peak. The peak's going to be in 3 weeks. And so I believe that in America, we're going to see outbreaks that move their way across pretty much every major metropolitan area over the course of the next 2 to 3 months. So in the US, my expectation and the predictions of a lot of people is that this pandemic is going to be raging at pretty high levels in various areas around our country for the next 2 to 3 months. But even after that, it will still be transmitted because we don't have a treatment and we don't have a vaccine, and we're not going to reach herd immunity because we've, reduced transmission. So even in the US, I would say late June, early July-ish, maybe, the transmission will be slow. My expectation is that after it peaks in specific areas, there's going to be attempts to return to normality and work. The only way I believe that we can actually do that is if we provide protection to the general population, which means masks for everybody, which means hand sanitizers, like in Liberia, at every door, in every office, in every building space, everywhere. I think those type of activities would allow a return to work earlier. I don't see that happening because of the current lack of that stuff. So in different countries around the world, we're going to see these waves. The best way to identify the wave in your country, if you know there's testing being done, is once you start seeing people that are diagnosed with, who are killed with diagnosis of COVID, it's circulating in the community fairly widely. And you can expect within the next 30 days that there is going to be widespread transmission, lots of deaths, and healthcare systems are going to be busy, if not overwhelmed.
Great, thank you. I have a number of questions around the spread again, and Khalid Juno is asking, everybody's talking about, is 6 feet good enough? People are talking about, sneezing and coughing, moving droplets to a longer distance, hospital corridors being infected and having and surfaces having droplets. What do you say to that? 6 feet or more or less?
So if someone is actively coughing and sneezing, 6 feet is not sufficient. And that's why they need to be wearing barriers. There's very good studies on it. They have, scientists are weird. They bring people in rooms and they make them cough all over the place, and they use spectroscopes to look at the droplets. And people actively coughing and sneezing can spread droplets for 3 or 4 meters. And so that's why those people have to have some type of barrier over their mouth. When you're just talking, you're spreading droplets. I'm spreading them now all over my computer here. And those generally don't transfer very far because you're not coughing and sneezing. And that's when the 6-foot rule is okay. But all bets are off when people are coughing and sneezing. So the patients who are doing that need to have a barrier in front of their face, period. No question.
How often, a question from Sabrina Crocklands, how often should face masks be changed? And with folks making masks at home, assume they need to be washed in hot water and bleach for X number of minutes, or do they need to be discarded?
Well, so the paper face masks, you can't wash and you shouldn't get them wet. And N95, the protection of an N95 is ruined if it gets wet. So that in particular, you can't spray it down with bleach water. I have a couple masks that I use, and I, at home, I have them, and I set them outside in the sun every day when it's sunny out, on both sides for an hour or 2 on each side. Because the UV light thing works, period. If it's a cloth mask, I don't know the exact rule, but the cleaning in Liberia for Ebola and around the world, cleaning with bleach solution is great. The recommended solution is 9 parts water, 1 part bleach. So it's a 10-to-1, it's a 10% dilution. The bleach in that water kind of denatures over a period of 2 to 3 days. So you need to frequently reuse that. I actually at home have a little spray bottle, and I use dish towels, and we go around our house and we spray the surfaces and we spray the door handles and wipe them down with our towels frequently. And the same thing should be done in all healthcare facilities. There needs to be cleaning staff going through every healthcare facility using bleach water to clean it all the time. The worst offenders for transmitting infections are your cell phone, it's covered in bugs, and your computer keyboard. And so it's imperative that those 2 devices be cleaned a lot. I clean mine a few times a day, even when I'm at home. So frequent cleaning with a diluted bleach solution is for either a cloth face mask or your devices is really important. Walls and particularly horizontal surfaces.
Great. This is a question from Amber Mahmood, and she's asking a more like long-term question about places where LMIC, especially where what are the chances that this could actually become a more complex chronic humanitarian crisis, especially in places where people are living under poverty line, and the interventions are going to perhaps affect them most. So long term, after this acute phase is over.
Well, we will develop the, so in the short run, the answer is yes, this is going to be a horrible humanitarian crisis. There's a great deal of concern about any crowded environment, particularly with all the refugee camps and the IDP camps for like Syrian refugees. And there's work being done to try to fix that. I'm not an expert. We're going to develop a vaccine for this. It's still well over a year away. But if this virus becomes endemic in the world, which it probably will, you know, this vaccine may be added to regular vaccine schedules. It may become part of what we do every year, just like the pneumococcal vaccine and the, you know, the measles vaccine, etc. So there will be a vaccine. It will help reduce transmission. It may have to be used on a regular basis in the future. That's a little hard to speculate on.
There's a question, and there's a lot of debate around that, discussion around that, from Amanda Burgess, and she's asking your thoughts on lack of testing and, and how this is driving transmission.
Oh, don't get me started. So, being an epidemiologist, here's how you control an infectious disease. You find a case. You then follow the contacts of that case and make sure they don't transmit it. In South Korea, they did an amazing job of doing that. Luckily they had a single point source, one church where most of their cases came from. They literally tracked down every person in that church and forced them to stay home. And they stopped the outbreak in their country cold dead. They did that because they tested everybody. So they found a case, they did a test, you have COVID, then they tested their entire family, then they tested their entire people they work with, then they tested the people who were tested from that test, and they were able to track down the outbreak. That's the same way we ended up controlling it in Liberia. Eventually we had enough testing that we could track down everybody and stop them from transmitting it. It has been an utter debacle, particularly in the US, that we have not been able to test anyone. But around the world, and like I started my discussion, we still don't have sufficient testing information to describe the behaviors and parameters of this virus. And to me, that's just, as an epidemiologist, it's egregious. It's appalling that we have reached this state with this outbreak that could kill millions of people and will kill millions of people. And we don't have the testing available. The way we intervene to stop an infectious disease is to test people and to isolate them and to find their contacts, to test them and to isolate them. And once we have those at least two steps, we can stop the transmission of the virus. And we aren't able to do that anywhere in the world except Korea. And Germany's doing a really good job of testing. And there's a couple scattered countries that are very effective in their testing strategies, but nowhere else. And that's the biggest problem we're facing right now.
Tom, a question from Muslima Ijaz from AKU. She, and I'm not sure if you're the right person or if you know the data on it. She's saying, may I know the role of plasma infusion from the recovered person to the infected people?
So I'm not an expert on it. I've heard about it. There are a number of studies going on, including with some colleagues of mine, on plasma infusion. From prior studies, there's been shown to be, in some circumstances, great benefit to plasma infusion and sharing the antibodies. In other studies, there hasn't been. But listening to my dweeby microbiology and immunology brothers and sisters, they're very hopeful that it is a potential strong intervention, but I have not yet seen studies.
Uh, I think a couple of questions around, so a colleague from Hopkins, Opiolua Ediwale, what do you think would be the best approach to be used in developing countries with high population densities, such as most African countries?
Again, I'm not an expert in that area. I'm very familiar with working in those areas. And I understand the constraints and the crowding, and I'm not a sociologist. I don't know how. In Ebola, like I said, people eventually became afraid and they quit touching each other, because social distancing in Ebola simply meant you couldn't touch somebody. Here it means staying 2 meters apart. And I can't envision in my mind how we would implement that rule in those environments. And I'm hoping somebody comes up with that answer.
A question from Dr. Badar Afzal. She is asking, she's saying, although in Pakistan, we are still waiting for the first peak and with nationwide lockdown is hopefully delayed, is there any prediction of a second peak worldwide?
So the models out there and the speculation by infectious disease epidemiologists, some people think that this may be like other respiratory transmitted viruses and have a seasonal pattern to it. The evidence on that is quite mixed. There's some studies out of China that show less transmission in warmer cities. But then again, the outbreak is spreading through Australia pretty strongly right now, and that's a southern hemisphere country, and it's summer there, or fall, early fall. And so it's not really known. Logically, if we're going to shut everybody down and prevent transmission, the transmission will continue after we don't shut people down. The goal of locking everybody down is not to stop the disease dead and cure it. It's to slow the transmission enough so that the healthcare systems don't get overwhelmed. We know definitively from China, from Italy, from Spain, from New York City, from Washington State, that the rapidity of the onset of this and the quick transmission of this overwhelms any healthcare system's capacity to respond totally and completely. So the goal of locking everybody up is to slow the spread enough so that the health systems and hospitals can maintain a quality level of care and not get overwhelmed. What that means on the back end, though, is that because transmission slowed, transmission is going to occur longer and continue on for months at a lower level. And I don't think anyone's willing to speculate on how long that would be. But if, for example, we clamp everybody down and we lock them up for a month and and suddenly you say, okay, it's good, we're fine, and we let them go back out, do their daily stuff, yes, there's going to be a second peak. Clearly, there's no way around that. So the question is how we maintain a low level of transmission and slow transmission in a larger population over a course of a number of months. And that's a difficult question.
Dr. Moeed Ahmed, he's a resident in emergency medicine at Aga Khan University, is asking, Italians, or even Chinese, I think, have had separate hospitals for COVID-19. In your opinion, is that the right call for LMICs?
No, because you don't have the resources to have regular hospitals. So no, the Chinese are unique in that they literally said, oh, we're going to build a hospital, and they threw it together in a week. And then they shipped in doctors from all over the country to Wuhan, literally thousands of doctors, nurses, and healthcare workers to man those hospitals. And so a lot of places aren't able to do that. In the US now, We are setting up field hospitals. There's, like I said, a hospital in Central Park that's being staffed by volunteers. But the rate limiting step in all of this is not the hospitals and is not necessarily the PPE. It's the staff. You know, you can't magically make staff up. And so just opening extra hospitals, the question is, how do you staff those? The Chinese, again, got away with that because they had a relatively isolated outbreak in a single province, and they have 1.3 billion people. But elsewhere, those models are much more difficult to apply. I do think that having separate areas initially and certainly having screening areas outside of a healthcare facility is critically important, at least in the early stages of the outbreak, to try to slow the spread into the facility.
Yeah, I know we are in the last couple of minutes, and I see if I can get two last questions, and both are very complex. So one is from both are from my colleagues, Priyanka and Bhakti Hansoti. So Priyanka's question was, and it says, what suggestions do you have for healthcare professionals to maintain their internal ethical debates while dealing with this particular crisis in the future, based on your experience?
So I have very strong beliefs in that after I worked in Haiti and in disasters around the world where I had to make decisions that killed patients. And I've always regretted that. And so the recommendations, if you read my article, my Washington Post things, are very straightforward. We need to remove the burden of making that decision from the provider providing care for that person. We do that two simple ways. One is follow guidelines, and the Italians put out guidelines. Washington State in the US just put out guidelines. The Spanish are putting out guidelines. New York State in the US put out guidelines a decade ago. There's guidelines out there about who you choose to die, you know, when you have limited resources. I think, frankly, lower middle income countries are more used to that because in a lot of countries, people work with limited resources every day. And so you don't just intubate everyone like we do in the US. What the heck? She's, 95 years old, we're going to intubate her. And so one is find a set of guidelines, follow it. And two, the decision to treat or not to treat an individual should be made by a separate committee or person that is not directly engaged with that patient care, who brings objectivity to that discussion. And so hospitals in New York, like Mount Sinai in New York, now has a committee formed of experts who, when it comes to that, will make deliberations 24 hours a day, 7 days a week on a very short notice as to, yes, we will intubate this patient, or no, we will not. So objective guidelines and an external committee helps remove that horrible moral distress that occurs when you're making decisions that lead to the death of somebody.
Last question, Tom. From Dr. Bhakti Hansoti. She says hi, and she said, what strategies can institutions and healthcare system adopt to mitigate the impact of service diversion on ongoing healthcare needs of the community? So maternal, child health, trauma, sepsis, etc.
Yeah, so that's very difficult. Sorry, I have to write something down here for my next call. The first thing to do right away is to immediately shut down all non-essential services. Anything that's elective, anything that you can block down needs to be done immediately. People tend to do a phased fallback of reducing services across the board, but certain things like trauma surgery, resuscitating heart attacks, stroke care, you can't get rid of that. And so ideally you isolate that to different parts of the hospital or different areas as much as you can. But there's no magic answer to that. In hospitals in Italy, it came to the point that where literally 90% of all patients in the facility were COVID related. In New York City now, talking to my colleagues at Mount Sinai, they've already reached where it's between 50 and 60% of every patient in the hospital is COVID related already, and they aren't near their peak yet. So that's a tough question. And unfortunately, I have to run. I have a big conference call that with my boss, so I can't be late to that.
Thank you, Tom, for your time. I really appreciate it, and I like to thank Talha and IT and Conference Secretariat at AKU, and my colleagues Nico Risco and Priyanka. Nico is working in the ED today, taking care of the patients. So thank you again, and we're going to be having these sessions twice a week, Mondays and Wednesdays, same time. So look out for our announcements, and have a good call, Tom.
Thank you very much. Everyone be safe.
Yeah, and sorry to those who couldn't answer the questions, but hopefully next time. Thank you all.
Yeah.
Goodbye.